After that wonderful talk on screening antibodies, possible future of preventing and hopefully one day cure, I'm going to go back to the grassroots, very, very basic, and I'm talking about redefining basic care in type 1 diabetes. So, long back when we used to talk about survival, today we're going to talk about that journey to complication free, meaningful life. So, at the onset, I would like to apologize because I'm going to be very unapologetic in the entire presentation, right? So, what is the purpose of basic care? And I'm talking about today, I'm talking about India in this century, in this era. And I'm talking specifically about India, who we are low resource, middle income, whatever we are, from high income to low income. So, if a child is diagnosed and getting free basic care and survives, gets repeatedly hospitalized, ultimately maybe dies with some complications at 40, 50, something, what have we achieved? Is that success or we have just prolonged the suffering? So, basic care that ensures just survival for me is not basic care. So, I think it's time. This was the situation 25 years back when I started work in Udan. Not a single surviving adult was there in the region where I come from. Not a single surviving adult. And that's why my work in type 1 diabetes started. But we cannot keep on talking about that era after 25 years. If today also my focus is only survival, then I definitely need to redefine my basic care. So, basic care is not minimal care. And I wouldn't settle for minimal care for anyone. I'm not talking in the remotest of village in India where anything today is possible. We just have to find a way. So we were often talking about just insulin, getting insulin there, some testing, and maybe emergency management hospitals are available. But that's a thing of a past. That's not something we can talk about. We cannot talk about just cost and charity all the time. So, basic care is the minimum standard required to live a long, complication free, socially and economically productive life. Otherwise, it's not basic. That is, we'll think about a word for that. So, survival is a starting line. We are not going to talk about survival. We are going to talk about a ultimate goal that we want to have, right? So, I want everyone here because everyone in this room must be working in type 1 diabetes. Otherwise, nobody attends a meeting with type 1 diabetes. So, if whatever care we are enabling, does the child attend school without fear? Does the young woman marry without secrecy? Does a young adult work without repeated hospitalizations? Can family live without constant anxiety? And if the answer to the care that is being provided in our centers is no, then our basic care has failed its purpose. Somewhere we have to introspect, we have to redesign, and we have to realign with that basic care. Somewhere we are compromising where it shouldn't have to be that way. So, five pillars, something very well established, yet I'm going to go through because these are, I have just one pillar which I added on my own, but five pillars. Physiological insulin replacement. We have moved from that era of premix. Unfortunately, India still prescribes premix. I would not like to endorse it as a temporary life saving measure because once on premix, it is extremely difficult to put them back on a basal bolus regime. So, yes, we can use NPH, we can use regular insulin, but not as a premix insulin. Right? So, insulin regime components, we know basal bolus, rapid acting is on essential drugs list in many of the states in India with the government, right? And why rapid acting? Because children in school, children who are working out, people on jobs, on travel, it makes life much easier. So that's one thing that could be considered as a basic care as well. And then, of course, giving them that flexibility because these are children, these are young people. So why is that not basic? Why is basic giving a very rigid system where you take two insulins or fixed time of meals? That is not going to get compliance. So ultimately, we need a very robust basal bolus dosing flexibility regime as a basic care. Meaningful glucose monitoring. So yes, glucose monitoring, yes, but if there's data that doesn't lead to action, then we are just doing surveillance. We are not actually making a difference. So only way to do that is also, and that is going to be the third pillar, and that is education. But are we aware what is a minimum way of doing it? What is a maximum? You can give 150 strips, you can give 200 strips a month, but if action is not happening, it is irrelevant. So meaningful monitoring is the second pillar for my point of view. Third is education, and it is not an add-on, it is part of the treatment. So I would say it very, very boldly and very, very bluntly. If I do not have a system to educate people and their families living with type 1 diabetes, it is incomplete treatment. It is almost unfair to give somebody insulin and strips without having a robust education system in place, which would involve a structured education, local flavor, local language, local context. Because without education, those supplies are wasted. People come with huge lipohypertrophies. Blood sugar levels are still out shooting out of the roof. There's no point in giving just insulin and strips unless and until it is with education. You don't have an educator, create one. You don't have a team, create one. Can't create one, outsource it. But there's no excuse to not have an education program into which a family with type 1 diabetes is enrolled. So that gives amazing outcomes. Even with limited resources, I have seen amazing outcomes. And with the best of resources without education, it can have extremely poor outcomes. So education is the strongest pillar. Fourth pillar, and that is something I would like to appeal to everyone today, is peer support and the psychological safety net. The one game changer that happens in a family that lives with type 1 diabetes is when they meet someone who is like themselves. Okay, let's say a person comes to us, we've given them all the insulin in the world, given them all the education, giving them all the monitoring equipment, everything is there. But where is the motivation to do this day in, day out? So the compliance totally changes. Person gets tired. In Udan, in where I come from in Aurangabad, when we give them supplies, initially they're very grateful, they'll take insulin, everything. And then it's day in, day out, they get bored and their results are pretty poor. What keeps them going back is when they have their peer group. When they see somebody doing well, they want to do better. So having peer group is an essential pillar. So I'll again say that find somebody. Somebody will be there in your town. Find a way to connect them. It can be online, it can be offline, it can be outsourced. There's so many wonderful groups in the country today. Connect a person with type 1 diabetes to another family with type 1 diabetes and see how the magic happens. Fifth pillar, very well established, is we do need regular follow up. So fortunately, this part is very well covered in government sector in India as well. Every hospital has all the investigations we need. We just need to tap them. When I looked into it, when we were trying to work with the district hospitals and looking at that, we found all the investigations are available in the government system itself. We just have to ask for them. And that is something we never realized, that they exist all the way from C peptide to everything is available. And there is a method in the government system where one can ask for a special investigation and the government will do it. You just have to justify it. The clinician has to do it. So this can be actually done free of cost, yet it does not always come in our basic pillar. So these five pillars are what is basic care for me. And I think in today's time, let's not compromise by saying, okay, we just have insulin, we just have strip supplies, everything else. Otherwise, that itself is not going to be effective. A small word on technology. Ideally, that is probably most needed by the people who are from the lowest resource. You know, where a mother who is illiterate working on a field cannot make decisions, cannot count carbs, cannot take the decision of dosing. That is the person who would absolutely benefit from automation. That remains a dream, and hence maybe a couple of years from now, when we're talking about basic care, once we have everything else in place, because that's what I'm saying, are we building systems that can absorb this technology? One day I would like to stand here and say, yes, that is the basic care. But initially, we have to get ready to be able to use those technology in an effective manner. And hence, technology is definitely there for the low resource. They need it most, and they would show the best of results because they are not capable of taking their decisions at times. So, basic care, I feel, for us should answer one question: does the child have a real chance to live well, not just live longer? So, every one of you who is taking care of young people with type 1 diabetes, is the care being provided gives them a real chance to fulfill their dreams? Is that 360 degrees, holistic care resourced at some place? If not, then we can't call it basic care. Then let's not congratulate ourselves at having done a good job. And then let us redesign the entire system so that the child does have a chance to have a better life. So, basic care is not charity. For the longest time, giving insulin was basic care. But we now know that that doesn't work. Yet the lifespan did not improve, complications did not improve because the other pillars of basic care were missing. But they are very much in place now in so many places. I just wanted to emphasize that let's not have a compromised care at all. So it's the ethical minimum of a life which is worth living. That I would like to say thank you. These are the children of Udan. Gratitude to one and all for making